Today's talk is on enhancing accuracy and efficiency and the power of new innovation in automated breast ultrasound. So we'll start with the breast density implications. Then we'll talk about the current guidelines based on risk stratification. What is our experience so far with Invinia, ABUS, the premium, the newest technique that we have, and also we'll present to you some illustrative cases. So we have learned through the years that women's breast varies. There is a great variation in the extent of stromal and epithelial component. You can see here on the left how much less ducts you see and also lobules comparing to the right side here. And this is how it looks. Apologies. This is very sensitive. And you see how the low density looks on the pathology slice and the high density on the side here. So it is a fact that one size does not fit all. So we have three different groups of women: women that have an average risk, women that have an intermediate risk, and women that have high risk. And today we'll focus in women that have intermediate risk. And which are these women? Are those women that have extremely or heterogeneously dense breast with or without any other associated risk factors, those women that have a personal history of breast cancer and are diagnosed with by the age of 50, and those that are having dense breast, and those women that have high-risk lesions, B3 lesions. So what are the challenges that we're facing in these women that have intermediate risk? First of all, those women do not have the same benefit from mammography. It means that due to masking effect, then the sensitivity of mammography is lower. Therefore, these women are usually diagnosed with cancers at a larger size and also greater grade 2 or 3 tumors. Also, we have an increased risk of having interval cancers in these women. Besides that, it is necessary and important to realize that these women have high risk of developing the disease. And this slide shows you the sensitivity, how much higher it is in women with fatty breast. Mammography reaches up to 93% sensitivity, whereas in women that have extremely dense breast, it is lowered down to 57%, almost 60%. It means that 4 out of 10 cancers would not be diagnosed because not that we're not good radiologists and we do not have experience, but because those cancers are hidden and they're not seen. And you can see here in the left the mammogram where it is obvious, even a non-radiologist can see the tumor mass here. However, as we go ahead on the denser the breast, maybe I use this, the denser the breast, the higher the risk of having an interval cancer. Like cancer is hidden in this area, it is not associated with microcalcifications, therefore it is missed. So what is the solution? Actually, we need to change the current screening programs, and instead of being based in women's age as it is currently, to change the future screening programs into risk stratification, where we should adopt personalized breast cancer screening. Therefore, earlier diagnosis of the disease will be in more patients. We have improved screening outcomes by reducing the mortality rate and also the interval cancer rate. And there is a great work that has been done by the world leading website about dense breast, which is the densebreastinfo.com. It's very well known in the States, also in Europe. Now in the States, they have done great work. You can see the map of the USA all highlighted, every single state highlighted in pink, where every state and every radiologist there is practicing at the moment after the new FDA national requirement for density that was effective since last year, and specifically since October of 2024, every radiologist is obliged to write down on the report the type of density the woman has and to inform the woman. Now there is a great work that we are doing under the Find It Early Act. There is a federal bill that is introduced to help ensure that all health plans coverage should be made also in screening and also in diagnostic breast imaging. And in Europe, we have been working in improving the knowledge of healthcare professionals in order to understand the implications of breast density and the need of supplemental screening. And here you can see on the photos Dr. Wendy Berg, with whom we have been collaborating since 2018, and also with Joanne Puskind and with Cheryl Crows from UK. More information came from the DANCE trials. You're all familiar from Netherlands, DANCE trial 1, DANCE trial 2. This trial showed that by implementing MRI, there was a significant decrease by half, by 50% of the interval cancer rate in women that had extremely dense breast. Therefore, there were new screening recommendations that came out by USOBI, suggesting that in women that have dense breast, extremely dense breast, and they're between the ages of 50 and 70 years old, a screening MRI should be performed every 2 to 4 years. Also, this guideline was associated with some important information that women should be informed about breast density and diagnostic and prognostic implications of having dense breast. This was the first time USOBI spoke out loud about breast density in European women. So I do believe that there were steps forward made after these guidelines were endorsed. More guidelines have been issued from other societies from the USA, where you can see here that in women with extremely and heterogeneous dense breast, the ACS, NCCN, or ACR are also recommending MRI, but they recommend annual MRI. In women with heterogeneously dense breast, USOBI recommends possibly to have breast ultrasound. Now we understand and we have a lot of experience. I've been very fortunate because I've been working a lot also with breast MRI in the past 4 years. The problem with breast MRI is that although it is a very sensitive technique in the diagnosis of breast cancer, the specificity varies, and also there is a lower acceptance rate. You can see from the Ukraine study and the Dutch trial that the acceptance rate is about 58 to 59%. And this is due to claustrophobia and also a lot of discussion that has been going on about the deposition of gadolinium in the brain, and also in some women they have allergies and they're very concerned about this. Now, the NCCN guidelines suggest that if contrast cannot is not feasible or available or accessible, the whole breast ultrasound is recommended. And a very new article came and was published in European Radiology by Magda Macron, highlighting that in women that have ACRC and D, you can see here on the flow chart, breast parenchyma, supplemental imaging with breast ultrasound and or MRI should be suggested. This is how our facility, just some photos from our center in Athens. It is called Athena Medical. We perform every imaging modality, also contrast enhanced mammography, MRI, automated breast ultrasound, handheld. We do all the biopsies. Our mission, vision, values, and leadership and quality improvement driven are aligned to patient-centered goals. Our care is collaborative and personalized according to patients' needs, where we perform the right test at the right time at the right person. And we evaluate about 10,500 women in our one-stop breast clinic, which was founded 3 years ago. Over 90% of these women are self-referred, approximately 70% are screening, and about 30% are diagnostic patients. And it is very interesting to see the workflow of our one-stop breast cleaning. It means that whatever is needed is done at the same day, without any waiting list or without having the patient coming back and forth. So we use AI, computer assistant detection, for breast density by Volpara. So we have Volpara scorecard in order to be more precise about the type of density that we have. Then we use the Tyler Cusick score. And then in women that have heterogeneous and extremely dense breast, we supplement screening with ABUS as the initial examination. If there are any areas of concern or any suspicious area, we perform targeted ultrasound at the moment, the same, the time. So the patient stays there, and then we deliver the results. Now, if there is any suspicion of malignancy, BI-RADS 4 or 5 findings, we do immediately the biopsy. Before the biopsy, we find a slowing, we do the MRI, and then we do the biopsy. And it is very interesting that we deliver the results, the pathology results, to our patients after 1 day. So especially for women that are coming in from abroad or from the periphery of Greece, from the islands and some other cities, they do not need to stay a long time, especially if they need to stay in a hotel. We organize weekly tumor boards. We do the staging. Also at our facility, we provide genetic counseling, psychological support, and also nutritional counseling for those women that are asking for these services. And we have multidisciplinary team. We have an oncologist, a surgeon, and all other relevant subspecialties. So we discuss the results of patient exams and further treatment options that are needed, and therefore we give the correct suggestion and recommendation to the patient about the treatment plan that is needed. So it happens that I do, as I believe most of you, a lot of experience with handheld breast ultrasound. I've been performing handheld breast ultrasound from 1997. When I was still at the university hospital located in Athens, called Areteo Hospital. So at that time, no one knew anything about breast density and very little about breast ultrasound. And we had a woman with, we were still working with film mammography, of course. We had a woman that had dense breast. So next day she went to her surgeon. Her mammogram was interpreted by me as negative, and the surgeon came in complaining that there was a palpable lump that was suspicious for malignancy. He had performed fine needle aspiration biopsy, and it was a cancer. So we took the patient together to the ultrasound department, and we checked the area of concern, and we saw that there was a cancer. So that was very disappointed for me, because actually I initially started my career in a fellowship that I had done in the beginning of my career on neuroradiology. Then I had a different direction on breast imaging. I thought breast was so simple that such a small organ, nothing could be missed. So it was a real disappointment at that time. And since then, I've been working with ultrasound all these years for women that had dense breast. We always perform breast ultrasound in women that have ACR, C, and D breast parenchyma. So it is a very accessible technique. Studies have shown that there is an incremental breast cancer detection, about 3 cancers in 1,000 women screened. Most of these cancers are node negative, it is important, and are invasive carcinomas. Unlike mammography, ultrasound is not really affected by breast density. And we evaluated in this study with Dr. Wendy Berg that was published in European Radiology more than 400,000 ultrasound examinations. However, with handheld breast ultrasound, there are several challenges. We know that this technique is operator dependent, so the result of the ultrasound depends on the experience the radiologist has. And in the States, a lot of ultrasounds are performed by technologists. This means that the radiologist is receiving static images for evaluation and not the whole examination. It's also time consuming. Um, and one other problem that we have nowadays globally is the lack of radiologists, experienced radiologists in Europe and also in Asia and in the States. Therefore, innovative techniques should and may help us to provide our patients more comfort and efficient experience and more reproducible techniques. This is how our ABUS room looks like. You can see the woman is in the supine position. The scanning is performed with a large transducer. Here is the evolution of ABUS. Well, we integrated our ABUS back in 2017. This was beginning of January of that year. So it's we have like 8 years experience. Then we went on with Invinia ABUS 2.0, and now we worked for about 3 months with the premium Invinia unit, and we'll talk about it more. So there are great advantages of automated breast ultrasound. It is a more standardized and reproducible technique. We have a large field of view, and this is because of the reverse large transducer that we have. You can see that it is curved, and it's actually manufactured like that in order to cover the entire breast and to have a better contact with the skin. We use a disposal membrane and also hypoallergic lotion. And the scan is performed automatically, starting from the inferior part of the breast, going up superiorly up to the area of the clavicle, and also from the outer. We receive different views. The basic ones are the AP, the central, covering the central part of the breast, the lateral and the medial. Sometimes, though, we need more views and more acquisitions in order to cover the entire breast. So actually, the number of scans we receive, it depends on the size of the breast. And so ABUS has a special software that after we receive the transverse images, they're reconstructed into this down here. You can see is the X-plane, the transverse. The one on the right is the sagittal plane, and one on the left is the coronal plane, the Z-plane. So whenever there is any area of concern, we have the possibility to read and be able to assess the suspicious area in 3 different planes. This is extremely helpful. We also have large transverse plane, so it is quite similar. I'm sorry for the spelling here. It is very similar to the image that you are used to with handheld breast ultrasound. And you can see here the difference between the field of view of handheld comparing here to in the bottom to the ABUS acquisition. So it is 3 times the image, the field of view with ABUS is 3 times larger, and the depth that we have is up to 6 centimeters. You can see here the coronal and one more acquisition on the right side. With only one sweep, we cover most of the breast, so we don't have to scan back and forth. We have post-processing capabilities, and those are extremely helpful. It's different to be able to work with the image once the patient is not in front of you. Also, you're able to see here different slices on different planes. So on the right side are the sagittal planes, and on top here the sagittal planes, here are the transverse, and this is the coronal plane. And the coronal plane has been very helpful because we have introduced a new descriptor that is called the retraction phenomenon sign. It is something very similar to the architectural distortion or stellate lesions that we have been recognizing with tomosynthesis. And there's a great value of the coronal plane. It is very unique because it helps us to improve our specificity and also our sensitivity. And studies have shown that the integration of multiplanar different planes, it helps us to downgrade 3 to 18% of benign biopsy lesions. Also now double reading is possible. You can see here, we double read or our ABUS examination. We get more precise comparison with prior examinations, like in this patient. Teleradiology now is possible. It is feasible because in some countries, supplemental screening cannot work because of the great distance between different cities. And AI now for ABUS, we've been working with AI for about 7 years, 8 years. It helps us to accelerate diagnosis and treatment decisions to maintain high service and patient satisfaction. It is also very helpful to evaluate image quality. We have AI for ABUS. You can see here how it looks like. You see the area encircled with green. It's the area of concern. It is a very tiny cancer. So it is very sensitive for detectability to detect areas of suspicion that are shown as black areas or black holes. And this is the correlate. This was of handheld breast ultrasound. This was a small invasive lobular cancer. So there are great advantages of ABUS versus handheld. It is a standardized technique. It gives us the great capability of multiplanar 3D imaging. So it gives us also post-processing capabilities. We have a large field of view and global visualization of the breast. The area of the axilla can be seen, level 1 left nodes, if we have included this area in the field of view of the image. Of course, we have AI with CAD, and there is lack of evaluation of vascularization, elastography, and there are no biopsy capabilities, and this is, of course, understandable. Now, what about the performance between handheld and ABUS? There is a comparable, the two examinations are comparable to each other. And you can see here in various studies that ABUS detects the same number of cancers per 1,000 women screened as handheld does. More importantly, the cancers that are detected in all of the studies are invasive carcinomas, node negative. I'm sorry, you need the picture, I'll go back. An interesting study that was recently published from Chicago has shown that there is ABUS, the utilization of ABUS, there is a great acceptability. And also this study shown that there were 2.5 additional cancers found per 1,000 ABUS examinations that were performed, and most of these cancers were primarily at early stage. Another study that came from China showed that the incremental breast cancer were 4 cancers per 1,000 women screened. And these are the results from the BRAID study. And I'm happy to see Iris here with us. So this study was done in Cambridge, where they compare ABUS versus contrast enhanced mammography versus abbreviated breast MRI. And the detectability rate in the first round was approximately 4.2 cancers per 1,000 women screened. Iris is here with us, so maybe she can share some information about the second round where we heard the great results yesterday. Those are the results from our study where we included 7,493 women, and we found 3 cancers per 1,000 women screened. So you can see here that ABUS detected 21 additional cancers that were not visualized on mammography. most of these cancers were invasive carcinomas. They were grade 1, and most of them were actually grade 2. Some of them were grade 1, and most of these cancers were node negative, and the medium size was 1.5 centimeters. In order to achieve great results, it is reasonable, as with every other imaging modality, that optimal image quality is necessary. Therefore, meticulous use of lotion is important, appropriate positioning, adjustment of depth, appropriate compression, and also we need complete coverage of the breast. There are several parameters that we use for successful implementation: assessment of image quality. Precise information about patient's history is extremely important. Comparison with prior ABUS exams, if they are available. Also correlation with with 2D mammography or DBD images. Also, it is important to be able to have access to targeted areas with handheld breast ultrasound to edit our results. This will improve our performance and will reduce our false positive rate. Now, our average reading time is approximately 3.5 minutes, and from the 8,000 women that had performed ABUS in our facility, the average examination time for 4 acquisitions per breast was 13 minutes. There was a great variation on the performance, so the advanced technologists, they had more experience, performed better, and very few patients refused of having an ABUS examination for their follow-up. There were 3 women from the 8,000 examinations that we performed, and those women had one was having a silicone implant, was having implants with liquid, was very frightened about having rupture. The other woman was very anxious and she was under some therapy, and the third woman had a pacemaker. The compression that we usually apply is moderate to high, and we'll go ahead with some information about the premium ABUS that is now available. It houses AI features, therefore it ensures that the entire breast volume is captured. It offers automatic nipple annotation. It reduces the scanning time by 30 to 40%. Therefore, you need less time for the examination. And though, to my eyes, I believe there is a great improvement on image quality. So we have a scan quality assessment where it gives all the information. It takes information about the area of the nipple, the breast tissue, the chest wall, and it coordinates all this information to make sure that positioning is correct and also that the entire breast has been covered. It also annotates by itself the area of the nipple in order to make it easier for our technologists. Also, you can see here that it is able to evaluate if the depth is correct. We have if it is too shallow fit or too deep. So we have also the coverage. So this is extremely important. And here we can go through a patient where on the left side, I'm afraid to touch this because it moves. On the left side, you can see the premium ABUS image, how it looks like. See? And on the right side, it is the previous ABUS 2.0. You can see more shadowing in this area with the previous unit, more shadowing. Now the structures are more well defined. More images of the same patient, previous and recent examination with the two, you're okay, I can go ahead, with the 2 different units. In some cases, this is a 69-year-old. Her family history was negative. She had a personal history of a fine near aspiration in the left breast and core biopsy in the right breast. Both of them were negative. Her clinical examination was normal, and we found on her ABUS exam a tiny hypoechoic irregularly shaped mass located in the left breast. Here on the right, you get by just clicking on the lesion, you get precise location of the lesion, area, distance from the nipple, and also distance from the skin. And these are the post-processing images and the correlates of the handheld image. This was an invasive lobular cancer measuring 0.8 centimeter grade 2 ERPR, positive KI 20%, HER2 negative. And this is the correlate images of the mammogram. You can see an asymmetry located in this area. Where is my arrow? In this area here. And the AI image, the QView cut, you can see the area here. This is the little cancer. Our second patient is 70-year-old. She had a screening mammogram, which was normal. It was performed at another facility. Her family and personal history was negative. There was nothing on clinical examination that was performed by our clinician. And you can see on her ABUS, this is the right AP, there is an irregularly shaped mass located at 11.5 position, also seen on the right superior and on the right medial. The correlate images of her MRI examination performed the same day, and the biopsy, this was an invasive lobular cancer measuring 1.13 centimeter. Although it was superficial, because I also performed handheld to this patient, it was not palpable, and the lesion on biopsy was extremely soft. This is the third patient, 55-year-old with breast implants, a screening mammogram. She had her end with breast cancer at age 40. No genetic testing was done. Greek women get a little bit emotional, and they're just afraid to have genetic testing. Although we inform them about the necessity, some of them deny, they do not want to find out. So we found on her mammogram just an asymmetry, which is very faint, and we cannot see it in any other image because of the breast implants. It makes our reading more difficult. We perform a focal view in this area to get more information. You see it doesn't spread out. And on her ABUS exam, we found a tiny tumor mass, taller than wider, located 12.5 o'clock position of the right breast. We perform biopsy. These are the correlates of the MRI examination, and this was an invasive lobular cancer in this patient. Our next patient is 42-year-old. This is with a previous unit. She has a known fibroadenoma in the left breast. Her tumor slices in the right breast do not show anything to be concerned. She has a heterogeneous, I would say, ACRC pattern. More slices of the right breast, and there is a mass on her ABUS examination, irregular shaped. For sure it's a BI-RADS 4 finding just with one glance. These are the correlates of targeted ultrasound. No significant vascularization is seen on color. Her MRI exam, and this was an invasive ductal cancer. Biopsy was performed under ultrasound-guided core biopsy, and then pre-surgical localization of the mass was performed under ultrasound. Our next patient is 62-year-old. She had right mastectomy 13 years ago, and then she had silicone implant reconstruction. These are her DBD of the left breast slices. Nothing is seen but her ABUS. There's a tiny mass located at 11.5 o'clock position of the left breast, very clearly seen. Also, AI depicted this suspicious lesion. You can see how it is nicely highlighted with green up here. And these are the correlates of handheld breast ultrasound, her MRI exam, and this was a tiny 0.6 centimeter invasive ductal carcinoma. So the take-home messages is that mammography has been done a lot all these years, the past over 50 years. Many women, thousands, hundreds of thousands of women have been saved, but we are at a point where we have recognized and acknowledged that mammography does not perform the same to all women. Therefore, women that have dense breasts have a lower sensitivity and supplemental screening is necessary. Now, the new ABUS premium unit provides AI features for scan quality assessment with great improvement on image quality. The acquisition time is reduced by 30 to 40%. The examination is even more comfortable for women compared to the previous systems. Also, AI is very helpful. It's not standalone, cannot be used all by itself, but it gives us a lot of help. It reduces our reading time, and also it improves our workflow and our efficiency. And with this, I would like to close this talk by presenting our automated breast ultrasound textbook for screening and diagnosis, which will be available for those that are interested by the end of this year. Thank you.